It's a pleasure to be here, and the first thing I have to do is really compliment Dr. Foster. Although he said we've known each other for 40 years, perhaps it was a little closer to 30 years, but either is still long enough. And I must say, to gather a group of people together like this who are interested both in the disease and patients who are affected shows what a significant influence he's had in the field as well as certainly in the area in Boston. It's interesting that this past week on the internet, there's a uveitis listserv of the American Uveitis Society. And unrelated to the fact that this symposium is happening today, a discussion started to ensue about birdshot chorioretinopathy. And in fact, I, as well as Dr. Foster and some other people participated in this. And it's interesting because many of the things you're hearing today are things which most of the experts with uveitis in the country have really come to some consensus on. And the last thing I would say before I begin is that Ralph Levinson mentioned a lot of what you're going to hear from me as well has been repeated before. It's usually stated that when you say something or you try to send out an advertisement or market, it's not until the 7th time that somebody hears it that they finally remember it. So you'll hear a lot of the same things, and maybe that'll mean it'll just stick a little bit more. I'd like to, first of all, recognize that the work I'm going to present to you was, in fact, greatly assisted by the participation of Dr. Nilofer Piri, who is at the University of Louisville as well. As you already heard, the natural history of birdshot chorioretinopathy is a chronic progressive disease with complications including vitritis, CME, retinal vasculitis, and progressive photoreceptor cell death. Although the etiology is unknown, it appears to be immune-mediated. And I believe, in fact, it's not just an autoimmune disease, but it's actually a compound of autoinflammation and autoimmunity, and I'll talk about this in my second presentation. The clinical manifestations of the disease are both subjective and objective, and they are definitely a reflection, as you've already heard, of what I refer to as both inner and outer retinopathy, because those are really, I think, almost two independent immune-mediated complications of this disease. To give you an overview, I'm going to talk a little bit about visual acuity, which you've heard a lot about just recently. We'll then talk about imaging, and when we're monitoring a patient, what sort of imaging studies that we do. We'll then talk about objective testing, specifically mostly electrophysiology, and then what's the role of subjective testing, such as visual field, color vision, contrast sensitivity, and then just very briefly tell you our personal routine in monitoring patients with birdshot chorioretinopathy at the University of Louisville. You've already heard Dr. Foster refer to the work of Dr. Folk. I, in fact, did my residency at the University of Iowa. Jim Folk was a young man when I was there. He was just beginning the residency as I was finishing. And he was the first, in fact, to publish that visual acuity alone is not an adequate parameter with which to monitor disease activity and may falsely suggest that a patient is stable or doing well. Dr. Foster went into detail about this, so I won't discuss that further. But he is certainly not the only one. Ralph Levinson and the group of colleagues that he has in 2006, slightly after Dr. Folk, also really came to the same conclusion. That even patients with good visual acuity, symptoms are very common, that there doesn't appear to be any relationship between the birdshot lesion characteristics and visual acuity, but most importantly, highlighting that the limitation of using visual acuity measurements for monitoring patients with birdshot chorioretinopathy. And that is obviously a message that all of us, I believe, are emphasizing. These, of course, are the classic chorioretinal lesions of birdshot chorioretinopathy, and indeed, if time permits, I'll show you how another disease that we just recently saw in a patient can very closely mimic this. And it's just that we happen to see the patient before these lesions developed, and actually a patient with a totally different disease. When we talk about imaging, Carl Herbert, who's in the audience, who will follow me after the break, will also talk about his work, and I suspect that a lot of what you're going to hear me say relates to some of what he's done. Well, one of the first imaging techniques we all will use is fluorescein angiography. And this fluorescein angiography shows massive very significant cystoid macular edema within the right macula, as well as retinal vasculitis and leakage of fluorescein from the retinal vessels, much more prominent in the right eye than the left eye, as well as leakage from the optic disc or optic disc edema. So fluorescein angiography is helpful in trying to establish and confirm the presence of retinal vasculitis and cystoid macular edema. But it doesn't really show us the lesions themselves, nor in fact one of the other features of fluorescein angiography, which indeed most people have not seen or reported at least, and that is a pseudoperfusion delay of filling of the retinal venous vasculature, and this is work by Dr. Herbert, and if you look at this very carefully, you'll see that in this particular patient, the inferior retinal vein, in fact, is delayed in filling, whereas on the ICG angiogram, choroidal vascular filling does not appear to be delayed. He referred to this as pseudoperfusion delay in Birdshot Retinochoroidopathy. More than fluorescein angiography in terms of looking at the choroidal lesions themselves, it appears that ICG angiography is indeed of most value. And the characteristic feature, again, this is work that was published recently by Dr. Herbert, and I believe he will talk about this further, are these dark spots that you can see on the ICG angiogram. This is the ICG angiogram here. These small focal dot spots, which are also occasionally associated with leakage from choroidal vessels, what he calls fuzzy choroidal vessels, probably relate to and are a consequence of the focal choroidal granulomas that are characteristic of this disease and that have been noted on the histopathology that has been performed. I just blew this up a little so you could see the dark spots a little more easily on this next slide. But in addition to fluorescein angiography and ICG angiography, I think one of the most important innovations recently has really been optical coherence tomography imaging. And in 2007, Antoine and his group published work showing the effect of Birdshot chorioretinopathy on the OCT image. And as you see here, what we now refer to, here was referred to as the third highly reflective band, but we would now refer to this as the ellipsoid region, shows that indeed in Birdshot chorioretinopathy, this area of the outer retina, and this again is a manifestation of the outer retina, is in fact significantly perturbed in Birdshot chorioretinopathy. We can't and would not have ever been able to recognize this without the advent of OCT imaging. And here again, slightly later, in 2010, is an example of a patient who presented with Birdshot chorioretinopathy, and you can see a focal disruption in the retinal architecture, particularly in what we call the COS, or cone outer segment, or the ellipsoid region, and with time it actually increased, but with treatment you can see that it's been reestablished and the patient's visual acuity, which was poor, subsequently improved. Again, this would have been not possible to detect without OCT imaging. Here is another OCT image which shows the presence of cystoid macular edema as well as atrophy of the retina on OCT imaging, whereas in fact on the fluorescein image, although you see optic disc edema and retinal vascular leakage, the cystoid macular edema is really not as prevalent as you can even see here on OCT imaging. But perhaps the most important development recently in this is what we call enhanced depth OCT. It is now, in fact, being further developed with swift OCT imaging, which really gives us an ability not only to visualize the retina, but really to start looking beneath the retina in the choroid. This is something I think which over time will give us even greater information. Here is an OCT image done with spectral domain OCT. The previous images were time domain OCT. And you see that outside the macular area, there was disruption of the photoreceptors, and that in the ellipsoid region, as well as a general thinning of the retinal architecture itself. Here's the focal disruption that you see, and there was a generalized thinning of the retinal architecture itself, and ultimately with involvement of the RPE. What was noted and what was reported in this publication, which recently came out, is that there are small clusters of these hyperreflective foci that are seen in the cone inner segment junction. And it was proposed that perhaps these hyperreflective foci represent clumping of the photoreceptors in response to injuries. I don't believe they're intraretinal pigment migration. And in fact, they're a reflection of the fact that the outer retinopathy indeed has continued and is resulting in permanent changes. As a consequence, this is a modality which in fact is very helpful in terms of our examining the retina, and in the future I'm sure will be even much more helpful as we better image the choroid to actually see the granulomatous changes that are obviously present in this particular disease. Well, those are the major imaging studies that are done. The next study that is an objective study is that of electrophysiology. And electrophysiological studies have demonstrated early loss of the oscillatory potentials and B wave amplitudes. Thus, Birdshot chorioretinopathy impairs the inner retinal function early. It's later in the course of the disease that the photopic B wave amplitude and the flicker responses are decreased, reflecting impaired outer retinal function, and I'll show you that in just a moment. It was actually Steve Foster with David Zaks who in 2002 reported that the ERG can predict success in tapering of immunosuppressive medications in patients with Birdshot chorioretinopathy. I'm not sure that's a universal prediction, but at least in some patients. They looked at 7 different parameters of the ERG, and what they found most significantly was that the implicit time in the 30 hertz flicker response, which is a cone, it's a photopic response, indeed was prolonged, and that that was associated with the recurrence of inflammation, and that this change disappeared with immunosuppressive therapy. Holder in 2005 again confirmed the fact that the most sensitive parameter for retinal dysfunction was the delayed implicit time in the 30 hertz cone flicker response. He found an improvement in retinal function following immune therapy in 8 of 12 patients, and therefore also concluded that ERG data can be used to decide when to start treatment in Birdshot chorioretinopathy patients and when treatment can perhaps be tapered. Here is an example of the ERG recordings that he noted. This is normal. Let's just focus at the 30 hertz cone flicker response. This represents the implicit time, and as you see, the implicit time initially, which is prolonged, ultimately becomes less prolonged with therapy and with a positive response to therapy. Although both the scotopic and photopic responses in ERG still remain diminished in this particular patient on therapy. And this is a different way of presenting the data, but when he looked at the implicit time improvement in milliseconds, you can see that in fact with treatment there was a significant improvement in implicit times as these patients in fact underwent immunomodulatory therapy. Janet Davis in 2005 confirmed the cone B-wave flicker implicit time was in fact most often associated with clinically important measures. She found some correlation with vision and duration of symptoms, but as I said, we really don't believe that vision can actually be reflective of what is occurring electrophysiologically. More recently, there was a review of the various parameters that can be used to monitor Birdshot chorioretinopathy, and again, emphasizing the implicit time of the 30 hertz flicker cone response was abnormal in 70% of the patients in their review at baseline, and that a normal implicit time is correlated with the chance that a patient can be successfully tapered from systemic IMT without recurrence. If time shows you, I will show you a patient in which that indeed is not the case, and I think it's something one has to be cognizant and aware of. So other than electrophysiology that can be followed objectively, what else can we do? Well, we can do subjective tests, and clearly one of the most important subjective tests are visual fields. And here again, Ralph and his colleagues in 2007 looked at a cohort of patients that was studied longitudinally with Birdshot chorioretinopathy, and what they found, as is noted here, that even with normal visual acuity, a variety of visual field abnormalities are seen. They used automated visual field testing to provide the objective measure of disease activity, and found that mean deviation was the parameter most commonly related to other disease characteristics, and that might be followed as a means of disease activity. This observation was confirmed by Jennifer Thorne and her colleague J.P. Dunn at the Wilmer Eye Institute in 2008. They used Goldman visual field testing because they believed it was more sensitive in detecting visual field loss when compared with the Humphrey automated perimeter. The problem is, unless you're in a special situation, this test is very dependent upon the reliability and reproducibility of the examiner. And so in most institutions, in most centers, you probably will still see the Humphrey automated perimeter used rather than Goldman visual field testing. But again, they noticed that the progression of Birdshot chorioretinopathy was associated with visual field loss, and that treatment with IMT may improve the visual field. This just shows that when patients, in fact, were receiving treatment, they indeed had an increase in their visual field, whereas when they were without treatment and immunosuppression, they, in fact, lost visual field. They looked at 36 eyes, which were studied both with the Goldman visual field and with the Humphrey field, and what they found was that of these 36 eyes that had an abnormality on the I4E isopter with Goldman visual field testing, only 14% were in fact picked up on Humphrey visual field testing, and that's why they felt that, in fact, if available, Goldman visual field would be preferable to the Humphrey visual field. However, they do go on to say that other tests, and indeed specifically electrophysiology, may indeed be more reliable because of this difference. More recently, our host also looked at visual sensitivity within the macula using microperimetry and found that patients who appeared to have inactive disease still had a significant decrease in threshold sensitivity below 16 decibels. And as a result, it suggests that not all patients, and we realize that, recover their full retinal sensitivity even when the disease is inactive, and even when they have what we would record as very good visual acuity. What other than visual field testing can be done subjectively? Well, color vision, Gary Holland and Ralph Levinson and the cohort of patients that they took a look at used the Lanthoni 15U test, and they indeed found that even if you had excellent visual acuity, you in fact could have color vision abnormalities, again, a reflection of the fact that visual acuity alone really doesn't give you a full insight into the impact of this disease. They found that color vision was abnormal in half of their patients. not only color vision, but Gary also published in 2009 that decreased contrast sensitivity is common in patients with Birdshot chorioretinopathy, and that it may occur in the absence of other visual changes. And you know, as Steve mentioned at the very beginning, I'm actually a retina specialist as well as a uveitis specialist, see many patients with age-related macular degeneration. And the most common complaint they indeed have is contrast sensitivity changes. And contrast sensitivity indeed is a reflection of changes that are occurring in the photoreceptors of the retina, but which we as physicians aren't really able at this time with the technology we have to be able to follow very closely. I believe we will be able to follow this as our imaging techniques get better, when we can not only count the number of photoreceptors, the cone photoreceptors that are present, but also the rod photoreceptors, and then when we can also determine whether or not the inner and outer segments of these photoreceptors appear normal. That's not something that will happen next year, but it's something that I think will clearly occur within the next 10 to 20 years. What is our approach at the University of Louisville? When we see a patient who has Birdshot chorioretinopathy, we do baseline studies. We take color photographs, do a fluorescein and ICG angiography, again, to rule out inner retinopathy as well as outer retinopathy. We do enhanced depth imaging with spectral domain OCT. We do the static Humphrey Visual Field 30-2. We do dark adaptation as well. And then follow both the full field ERG, particularly looking at the cone flicker response, as well as the multifocal ERG, because we use that routinely when we do electrophysiology testing, and indeed have seen abnormalities in the multifocal ERG, which again are a reflection of ongoing disease. We repeat this every month, regardless of the clinical appearance. If patients even appear to be quiescent and their visual acuity is fine, we repeat these tests. And we repeat these tests whether they're on therapy or they're not on therapy, in order to be able to follow them closely enough, because we have had too many patients who we thought the disease was quiescent and then ultimately found out, in fact, they were losing significant visual field and had other visual changes that indeed were very bothersome. We do enhanced depth spectral domain OCT imaging at each follow-up visit to check for the presence of cystoid macular edema, an epiretinal membrane which can develop on the surface of the macula, or an alteration in retinal architecture. We'll repeat the imaging studies, fluorescein angiography, ICG angiography, if the visual acuity is decreased. I see I have 5 minutes left, and I'll just show you two brief cases, which I think you'll find of interest. One patient was a patient who had a local follow-up with loss of vision, but not only that, the most interesting thing about this particular patient is I first saw him close to 25 years ago. Actually, maybe closer to 30 years ago now, but close to 25 years ago, when I was in St. Louis at Washington University, was referred to me from Alabama, who presented with Birdshot chorioretinopathy, and it was HLA-A29 positive, and we treated him initially with corticosteroids and then placed him on immunomodulatory therapy, and he was doing very well, had 20/20 vision, and then suddenly showed up about 2 years ago after not seeing me for about 3 years, because he was continually followed by his retina specialist in Alabama. And at that time, because his disease looked quiet, they stopped his immunomodulatory therapy. And he didn't notice that he really had lost any vision, but he came because his wife had a problem. And they now thought she had Birdshot choroidopathy. So after 20 years where he had Birdshot choroidopathy, she came in with a diagnosis of Birdshot choroidopathy. Now, you realize this is not the same as having monozygotic twins. This is a husband and a wife. So they're genetically quite different. And indeed, she came in and she had classic presentation for Birdshot choroidopathy. We genotyped both of them to see what subtype they had, and they both had HLA-2902. So here you have a husband and wife, had the same genotype, have lived together for several decades, and then ultimately, whatever it was that triggered the disease in this man simultaneously triggered the disease in his wife. That certainly sounds to me like something was transmitted from one to the other. and how it was transmitted and what it was that was transmitted. I'll try to give you a little insight in my next presentation when I'm supposed to talk about corticosteroids, but because corticosteroids are really only used for an acute, the acute onset, I've spent a little time talking about how I think the disease, in fact, evolves. At any rate, this is what he looked like when I saw him recently. He had 20/50 vision OD, and he was now at less than 2200 OS. This is a fundus autofluorescence. You can see the lack of fluorescence in a significant part of his left eye and in the peripapillary area of his right eye. And on spectral domain OCT, he had significant disruption of the cos outer segment and the retinal pigment epithelium, as well as retinal atrophy. When we did fluorescein angiography and ICG angiography, he looked relatively quiescent. There really wasn't any leakage. What you're seeing primarily are window defects that were present. On visual field, he did have an enlarged blind spot in the right eye, as you would suspect from the peripapillary atrophy. He had lost, obviously, functional vision in his left eye. And this is after 3 years of not being on immunomodulatory therapy, without his being aware of it. And this is not uncommon in patients with many different diseases that first begin in one eye. They gradually adapt to the fact that they're not seeing well in one eye, and frequently will come in and only realize they've really lost vision in the first eye when suddenly something happens in the second eye. His 30 hertz flicker response, you can't see it here, but clearly the B wave amplitudes were dramatically decreased, but the implicit times were also prolonged, worse in the left eye than the right eye, and his dark oscillatory potentials were totally inhibited and gone in the left eye, although they were still present in the right eye. So that was the first case. The second case, which I'll conclude with, this is a patient, a 46-year-old Hispanic woman who came to us complaining of 20/40 vision in both eyes, and had what we would consider classic Voigt-Koyanagi-Harada's disease. She had multiple neurosensory detachments with vitritis, no lesions in the eye that you're seeing here. We treated her with systemic corticosteroids. Her vision came back to 20/20 in both eyes. The vitritis resolved. Everything was fine. Suddenly she comes back 6 weeks to 8 weeks later, and all of these lesions that weren't there before are now present. Now these lesions, one might say, well, you know, these certainly look very compatible with what we would call Birdshot chorioretinopathy. Here there are lesions as well. She is not HLA-A29 positive, and I think indeed this is a patient who, in fact, presented to us with what looked like Birdshot chorioretinopathy, but obviously was probably Voigt-Koyanagi disease in resolution. But what was fascinating is we then did enhanced depth imaging on OCT, and look what's there. This is a much better image than you've seen in the other pictures, and this is with the spectral domain OCT enhanced depth imaging. And you see these hyperreflective foci? Those are the same hyperreflective foci that were reported earlier in patients with Birdshot chorioretinopathy. And obviously this is a consequence, I think, of some photoreceptor dysfunction and some damage. And it may not indeed be at all pathognomonic or solely associated with Birdshot chorioretinopathy. And this was present both in the temporal, as you can see here, was both in the temporal retina as well as in the other eye. Thank you very much.